I am Atakan Varol, founding director of ISAI. This is our fourth video for our COVID-19 simulator for Kazakhstan. In this video, we show the results of our simulations for different strategies. I thank to the ISAI team for developing this application and also specifically to research assistant Aknur Karabay for generating all the simulation results which will be shown in this video. I would like to remind you that our simulator models the whole country as a number of nodes corresponding to regions and big cities, and also models the air, rail, and highway transportation between these nodes as the edges of this network. In each node corresponding to a oblast or city, we are running a SEIR epidemic simulator consisting of susceptible, exposed, infected, and immunized states. Even though our model can take into account vaccination, we are aware that there is no vaccine for COVID-19 yet, and therefore it is reserved for future use. Normally, a susceptible person enters to the exposed state where he or she might be quarantined. Then they transition to the mild or asymptomatic infected state, either in the isolated state from the quarantined or either in the infected state from the exposed. And from this mild or asymptomatic infected state, they can transition to the severe infected. And in severe infected, they might either unfortunately pass away and transition to the death state. They might go to the recovery immunization state or back to the susceptible state. In this stochastic epidemic simulator, there is a probability for all of these transitions. And essentially, we are running a stochastic differential equation for this model. We can approach epidemic control or epidemic mitigation or suppression as an optimization problem. The ingredients of this problem would be an epidemic model that can closely project future trajectories of the system states based on the set of inputs. The states would be number of infected, exposed, susceptible, and death. And the inputs would be the actions or measures taken by the state, such as transmission rates for each region. This value would change based on the taken measures such as lockdown or social isolation. Quarantine rate of the exposed for each region. Vaccination rate for each region not yet available. And disconnecting or reconnecting some of the edges of the network. This would basically mean that we are opening or closing the transportation between different regions of the country. The cost function would be a function which determines the quality of the epidemic response based on the measures. For instance, one might say that the cost function should be minimize the number of deaths. An optimizer would be some type of algorithm which minimizes the cost function. This might be simply a graduate student who tries different parameters using his or her insight, a classical optimization theory algorithm, or indeed an artificial intelligence algorithm. However, the problem is not very easy because here in this problem, we don't know what the right cost function should be. The hardest part is to find the cost function. Why is the cost function hard to find? Firstly, it is due to the narrow domain of our epidemic model. Our simulator only models the dynamics of the disease. It does not consider the effects on the economy and other problems of the society due to the measures taken. Secondly, there is no cost defined for a human life. Human life is priceless. It is very hard to quantify the value of a human life versus the hardships, economic or social, due to the measures taken to control the epidemic. Indeed, it is even very hard to quantify the cost of the deaths of different persons. For instance, in our model, the death of a 5-year-old is the same as the death of an 83-year-old person. A 5-year-old child has 80 years of remaining life versus the 2 years of expected remaining life of an 83 years old. And in addition to this, there is uncertainty about future events. The virus might mutate to a more deadly form. We don't know whether this will happen or not. A miracle drug or vaccine might be introduced by a company. Unfortunately, we don't know the dates and probabilities of these type of events. That just kind of makes it very hard to find a cost function for this problem. So what will we do? It's very hard to find a cost function. We will develop different scenarios, simulate them, and assess their results with human reasoning for deciding the best strategy. Strategy 1. Complete lockdown until the epidemic is over. We might continue the present emergency state in the country until the epidemic is over. We will stay at home except for essentials, online work, online education, no travel, no shopping centers, no sport or cultural events. Even under these circumstances, there will be some interaction between people, for example, healthcare workers, law enforcement, basic utilities, grocery stores, and critical facilities. Assuming beta, the transmission rate can be decreased to 0.03, our simulations indicate that the epidemic will last till the end of November 2020 in Kazakhstan, with 37 total COVID-19 related deaths. So this is, with respect to the number of deaths, the best scenario. However, there will be lots of other problems. The cost to the society will be extreme. There will be economic problems such as unemployment, contraction of the economy, inflation. There will be other health problems which our model does not consider. Psychological issues and higher suicide rates due to constant isolation, increased marital violence and divorce, other health issues due to the sedentary lifestyle. Another risk is the lack of herd immunity. Once the international travel starts again, the disease will start with high likelihood again. Here are the simulation results for scenario 1, 30 March 2020. This is the simulation results for 30 May 2020. As you can see, the number of infected is decreasing. This is 30 August 2020. We have 16 infected in Kazakhstan, 5 exposed, but still we don't finish the epidemic. It is still continuing, even though the numbers are very, very small right now. Sometime in the November, the epidemic ends. Here is a snapshot from 3 December to 2020, and there are no infected or exposed persons. Let's consider another strategy. Strategy 2 is simply go back to normal and hope things will be fine. Let us assume that the present emergency state ends in the country on 14 April 2020. We go back to our daily lives, we wash our hands more frequently, and do some voluntary social distancing. This would slightly reduce beta values compared to the original beta values. Our simulations indicate that if we relax the measures after the extreme state, the exponential rise of the epidemic starts again. Here are the simulation results for 8 April 2020. The measures are being lifted on 14 April 2020 and life goes back to normal. Already 1 month after the measures are lifted and life went back to normal, there are 480 deaths and the number of infected and exposed skyrocketed. When we come to June, there are more than 10,000 deaths in the country. So apparently, this strategy is not a viable strategy because it will result in a very high number of deaths. So let's create a new strategy. We call this prepare and create the new normal because our lives will not be the same again until a vaccine or miracle cure is discovered. If it is not possible to continue the extreme measures for many months due to economic and social problems, and if we don't want to have very high number of deaths, we should adopt a hybrid strategy. Let us assume that we prepare and start the new normal on 14 April 2020. The objective is to enable the society to operate as normal as possible while minimizing the number of COVID-19 related deaths. Maybe this might be currently employed by South Korea and Taiwan, who are controlling the disease quite well until this date. While living in the new normal condition, one of the following developments might happen. A new therapy which decreases mortality rate might be introduced. That would be great. A new vaccine which enables vaccination immunization might be introduced. That would be great as well. And maybe in the summer, when the temperature and humidity are higher, the COVID-19 transmission would decrease. What are the preparations for decreasing the mortality rate? Firstly, we should build hospitals in major cities to treat COVID-19 patients. We should increase the number of intensive care units and critical equipment for COVID-19 treatment. We should ensure the supply and distribution of critical drugs to the hospitals. We should improve the air quality in major cities such that people have healthy lungs, and we should provide services to elderly and other vulnerable persons such that they can social isolate themselves. Note that these lists are by no means comprehensive. We created these lists after brainstorming and studying the measures taken by other countries. To benefit from the wisdom of the crowds, we invite medical professionals, public health experts, and others to provide their valuable suggestions as well. And here are our suggestions for decreasing the transmission rate of COVID-19 in the new normal state. Ramp up local production of personal protective equipment such as masks, gloves, goggles, and hazmat suits, and make sure that all healthcare personnel has access to these. Masks should be mandatory for using public transportation and visiting busy places such as malls. The testing capacity for both COVID-19 disease and COVID-19 antibodies must be increased. Testing facilities should be created which minimize transmission of the disease, similar to the drive-in testing facilities in South Korea. Mandatory home quarantine should be introduced after traveling between different regions. The broadband internet access should be improved in the whole country to enable online working and learning. Employees should be allowed to work from home if their presence at workplace is not mandatory. For instance, we can use electronic signatures. Sports and cultural events should start in the new normal, but without spectators, and they should be broadcast online or via TV. And for an additional strategy 3++, we propose the creation of a mandatory national COVID-19 tracking application for smartphones to utilize big data analytics to control the disease. Simulation results for 30 March. Simulation results for 14 April. After this date, we will start the new normal. Even though we took lots of precautions and made lots of preparations, we see that the epidemic is not rising very fast, but it is still increasing. On 1st of May, we have 41 deaths. Epidemic is still somewhat controlled, but the number of deaths, number of infected and exposed still increase. So this just shows that this set of measures were not enough to completely control the epidemic based on the parameters which we have entered to our simulation. And when we fast forward to 30 July, approximately 2 months later from the last snapshot, we see that the number of deaths have already approached the 5,000, and there are lots of infected persons in Kazakhstan. Apparently, the new normal, at least for the given set of parameters which we have used, did not control the epidemic. The epidemic possibly might be curtailed or controlled if we use big data analytics and ubiquitous tracking of individuals and keep the people at home who have a high risk of having the disease. For this, we are suggesting a Kazakhstan national COVID-19 control application for smartphones. Firstly, nearly all adults in Kazakhstan have smartphones. Data transmission and GPS localization capabilities of these phones can be utilized to control the COVID-19 epidemic. Each adult will have to install to their registered phones this application. Outside of home, every person will be required to carry their smartphones with this application installed and running. Outside again, law enforcement will check whether the individuals are carrying their smartphones with the installed application. The app needs to be shown to enter busy places such as malls or different transportation means. The longitudinal location data of each person using the application will be warehoused in a data center. This data will be mined strictly for public health purposes in real time. We are aware of the possible privacy concerns, but this is just a hypothetical discussion. For instance, if a cashier in a grocery store tests positive for COVID-19, the app will be able to identify the contacts, and contacts will be requested to quarantine themselves at home for 14 days. Their app will change its display color to red, and this way the contacted individuals will not be allowed to go out. because in case they will be checked by law enforcement or while entering to a public transportation, their app will show this color, and that way they will be fined, or they will just not taken to the allowed into the public transportation. This will effectively increase the quarantine rate of the exposed in our model and decrease transmission. We are estimating that approximately 1% of the population will be under constant quarantine at home, but 99% of the population will be able to go on with their daily lives. We also made some back-of-the-envelope data calculations for feasibility of this approach. Let us assume that we will track 10 million smartphones in Kazakhstan, and we will transmit the GPS-based position of the smartphones as 32-byte packages every 5 minutes. This makes 288 data packages per day to a data warehouse. Accordingly, the total daily log size would be 10 million smartphones times 288 packages per day times 32 bytes per package, and approximately 92 gigabytes. This is much less than a movie. The total log size for 1 year would be 34 terabytes, which would fit into 5 8-terabyte hard drives, which you can buy at the Technodome store. Now let's have a look at the network load calculation. Let us assume that the TCP/IP package to send the data to the warehouse is 60 bytes, including the header. Data transfer rate per second can be calculated as 10 million phones, 288 messages per day times 60 bytes per package divided by 86,400 seconds per 1 day. This just is approximately 2 megabytes per second. Currently, the broadband internet connection of your home most probably is higher than this rating. And even if we have this data, can we do proper contact tracing? Let's assume that we want to track each day the contacts of 1,000 infected persons who have been confirmed using the tests for the last 2 weeks. For each person, we would have 14 days times 288 position entries to where they have been, and accordingly we will have approximately 4 million total locations. A lazy search would require 4 million times 10 million distance computations, which is approximately 40 trillion calculations. This might appear like a very big number, but still with high-end workstations and servers, this is not that high. And this can be reduced by orders of magnitude using space partitioning data structures such as KD trees. In general, this part is also feasible. Before proceeding further, we would like to make a disclaimer. We are scientists and researchers. We are neither recommending nor not recommending the tracking of individuals using their smartphone position data. We only highlight the technical feasibility of the approach and show how it would affect the spread of the COVID-19 disease in Kazakhstan based on our simulations. Here are the results for the scenario 3++ on 14 April. Here are the results for 1 May 2020, 17 days after the new normal state has started. As you can see, we don't see an exponential rise of the number of infected or death. The total number of deaths as of now is 55. 1 month passes, and here are the results for 30 May. As you can see, still the exponential rise is not observed. The epidemic is controlled. The total number of deaths reaches 86. But you should take into account that the life in the whole country is normal, and people are going to their works. There is no strict quarantine for the whole population. Another 1 month passes, and we see the number of immunized people in Kazakhstan increasing steadily, but the number of infected is more or less steady with a slight downward trend. The total number of deaths for this scenario is 147 on 30 June 2020. These results show that preparing for the new normal and living our regular daily lives with these precautions and measures, with the addition of ubiquitous tracking using our smartphones, might be the way to proceed to cope and control the COVID-19 epidemic. Here are the results for the 30 July 2020. The total number of deaths is 214. We did not have to use, thanks to these measures and applications, the extended hospital capacity in the country, and the epidemic is in the downward slope of getting finished. In this series of presentations, we describe the design of a sophisticated epidemic modeling tool, calibrated with historical data and recent experience of COVID-19 in different regions of the world. The simulator incorporates factors such as population demographics and mobility, hospital capacities, and propagation characteristics of the virus. The simulator was customized for use in the Republic of Kazakhstan in order to evaluate scenarios based on the projected outcomes of policy decisions. On one extreme, the lack of control will yield unmitigated disaster with overwhelmed healthcare system and high rates of mortality. On the other extreme, persistent suppression via quarantines and strict social distancing will cause economic harm and instigate other forms of social distress. The projections of the simulator suggest that, going forward, it will be necessary to maintain some level of social controls, labeled as option 3++, so as to constrain propagation and minimize social and economic impact until such time as the so-called herd immunity is gradually achieved or a vaccine is introduced. It should be noted that our simulation results show the general trends based on the entered set of parameters. More realistic epidemic simulations can be done when more accurate estimates of the infected and immunized can be obtained by extensive randomized testing of the population.